Anjana, I know her for the last 20 years. Very good pediatrician with social outlook, and she is doing lot of service. And she is a developmental pediatrician from Mumbai.
Good morning, everyone. So I will be starting, I'm going back to basics. And while we had such a wonderful talk on DMD, at least the impression is created that we have to look at chronic medical conditions and detect and start giving them the academic support as early as possible. So that's a very important take-home message from the early. Yeah. Can you start my presentation? I want to know how many of the audience we have a lot of medicos or we have a lot of rehabilitation people. Rehabilitation people can, all the therapists and all can raise hands. Okay. So a lot of medicos, interesting. Now what happens?
You start the PPT. Start the PPT. Yes. And this is the slide I need. She's a director in Nirmaya Hospital and director PEHL services, and she's national chairperson for growth and developmental behavior in pediatrics. And I worked with the module, IAP module. There's Cradle to Crayon and beyond, and she had more modules like growth monitoring, developmental delay, autism, basis of behavioral module. She's working for the past 20 years for the sake of children with special needs and doing lot of service and giving actually home-based treatment for, and also she talks in YouTubes and other things and helping these children with special needs out of the way. Congratulations, madam, for the total efforts you are putting for the sake of children.
Thank you, sir. Thank you, and let's move on. Now here, I would want a little bit of introduction. This is, and these, all the 5 cases which I've just put in within last 1 month, which I've seen. I work at the Learning Disability Certifying Center in Mumbai at KEM Hospital, and we see more than 50 children every week over there, and over last 20 years. So I just picked up some latest cases, and which are really, I wanted to put the point across here is, this is a girl, Sheetal, who's 15 years old, 10th standard student, was referred for poor school performance. There's been no risk factors. We'll come to the risk histories later. No risk factors at all in the birth history, developmental history, medical, or any drug history. On evaluation, she read very slowly with a lot of mispronunciations, guesses words, makes a lot of spelling mistakes, has poor written expression, poor handwriting, and calculation errors. Now, is this enough for any kind of diagnosis? Now, when I go back to the history, this child has undergone evaluation earlier. Later, again at 2020, when the child was in 7th standard, and still the child has such severe problems because there was no intervention done. This is Thomas. He's 18 years old, 12th standard, commerce at this point of time. He was a preterm child with long NICU stay and required ventilatory support during the NICU period. He underwent some form of early intervention when he was around 6 years of age. The mother gave the history. We went to a center for nearly 1 year and we did some therapy. That was 10 years back at least, and the child did not have any paper. I mean, the mother didn't give any papers as to what was documented or something. This child, believe me, when we did the assessment, he's 18-year-old, extremely sincere fellow with good attention and obviously trying, but his academic level was 3rd standard. Now this child has undergone evaluation, some therapy 10 years back and nothing in between. And when I asked the mother the reason for the same, she said, I thought he was doing well, I didn't know what's going on. 3rd child, very clear cut, Surya, 7-year-old male child, 7-year-old, that's important here. A 7-year-old male child comes to me for assessment. Obviously he is Down syndrome. There's been no intervention till date. And this child has been to a pediatrician. I mean, while we are talking of such, advanced treatment of DMD, we are actually failing as doctors, not even advising proper intervention by 7 years of age. This child at present is walking and climbing steps, but says only 2 to 3 words with meaning. Obviously, there's been no schooling. When I asked the parents, why didn't you do anything? So the parents said, when he was born, looking at him, my doctor told me that he will not even walk. So we just gave up on the child. Can you believe that? Another possibility could be, any guesses anybody would say, it could be a dual syndrome, wherein you see the combination of Down syndrome with autism. Because he's obviously started, some catch up on the motor development has happened without any intervention, but the child is not saying anything at all. By 7 years, you would expect the speech to come in a typical Down syndrome child. So my guess is that it could be, though the child didn't have too much of autistic features on examination. So this child, again, no schooling, and we've missed the entire early intervention phase. This is another child, Samira, 13-year-old, 8th standard, referred for hyperactivity by the plastic surgeon who has done the cleft lip and palate surgery for him. So there have been 3 surgeries, I think twice or maybe thrice this child. 3 surgeries have been done, and the child is followed up for good 10 years with the doctors, but the child was never advised any intervention. So this child and even last week when the child came to me, it was for hyperactivity. It was not for anything else the child was sent to me, not for academic backwardness. So this child came on evaluation, has strong nasal twang, has many misarticulations and unclear speech, and academic evaluation, a lot of spelling mistakes, and the grade level which is 4 years below the grade the child is currently in. This is Ahmed. He's 15-year-old child referred for academic backwardness. Medical history of right hemiparesis with seizure disorder. He's still on medication but very well controlled. This child on evaluation had an average IQ, fair performance in languages, but difficulties in calculation and maths reasoning. Now this child is in fact so well supported and a lot of early intervention, because this child went on for physiotherapy, got good OT support, did a bit of special education, and does not seem to have much of a problem except for the maths, reasoning and calculation. So the point which I want to drive here is, we as pediatricians somehow feel that we are only responsible. Of course, there's a lot of awareness. We are talking about a lot of developmental issues with the children, but somewhere we are not able to help them as we must. So we need to understand which are the high-risk children, which definitely need some. I will talk more on the ways and how we are supposed to help them. So if any child has developmental concerns, that child needs to be monitored and followed up. If a child has difficulty walking or talking, the child will have difficulty in learning higher language skills and processing a lot of information and cognitive abilities somewhere. So that is a message. So children who are high-risk neonates, the children who are born preterm, the children who have undergone ventilatory support, the children who have chronic illnesses, like, I was talking of, I gave you example of a cleft lip, cleft palate, DMD. I'll give you a couple of more examples. So any child who is missing things, school also for chronic, like even thalassemics, if they're missing schools for repeated blood transfusions or related illnesses, very severe asthmatic child. So all these children have to be, you have to have an anticipatory approach here, that this child will have developmental and academic issues later on, and that needs to be communicated very well. Then comes neurological disorders, mainly epilepsy. All of us see a lot of epileptics. Even in general pediatrics, they usually would not go to neurologists until unless it's a resistant epilepsy or a syndromic epilepsy. So and we manage them well in our clinics, those children always have the risk of developing academic backwardness or poor school performance later. Sensory deficits is very important. For every child who's coming to you, as a routine, we need to, at some point of time, get a hearing evaluation done and a vision evaluation done. I have seen children missed out with color blindness pretty late in life. Because they come to us for academic backwardness, they're not able to interpret certain colors. So that's again a common thing which we see. Squint is something which is very obvious. ROPs is something which is picked up, but we are not picking up these subtle ones. Unilateral hearing loss is something which is missed out. So sensory deficits have to be ruled out, and that is one more very, very important thing. Now, the child may be doing badly because his cognition per se is low. So cognition per se is low would mean that his IQ is less than the average of 90. So the children who are in the IQ of 70 to 90 fall in the slow learner category, and these children will find difficulties coping up with a regular curriculum which is planned for children with average IQ. So they will have some academic problems, but the children who are in their IQ of 80s and all may show problem more in the secondary level. Then ID is the children with intellectual disabilities, IQs less than 70. Now, you could also have ADHD along with, which would be the cause of academic backwardness, or you could have ADHD as a comorbidity for specific learning disability. So since the discussion is on specific learning disability later, I won't dwell much. ASD also could have academic backwardness, right? And this we are talking of high functional children who are going to regular schools and not much of a sensory issue or a behavioral problem, and of course verbal. Mental health issues, children with depression, children with generalized anxiety disorders, children with school phobias, these are the children who would have, one of the cause for academic backwardness could be there. And genetics. Genetics we don't see much, somewhere a lot of literature, but somewhere around 20% also could be there. And we do see a lot of family history positive, but again, we don't have any way of knowing because the parents have not been tested. We have started seeing now the second generation, when the parent have had and the child has a problem. So since we have been running this clinic for 23 years at KEM Hospital, we do see a few of them turn up, but not a very common thing. Now, while we focused on the intrinsic causes, extrinsic causes are very important. One thing we'll come to that, but once we take the academic history and we see if the child has shifted schools, moved from one curriculum to another curriculum, which people do a lot. They move from the state curriculum to the central curriculums to international curriculums, or moving places, or a shift from the pre-primary to primary to secondary. So those are the stages. For a 1 year gap you can give them for them to adjust to the new way of method of learning. So educational, there could be a problem with the school, there could be problem with the teachers, so these are or there could be bullying at school, there could be some other issue at school. So these could be the educational related extrinsic factors which could present as child not doing well. Family related, we do see a lot of broken families, domestic violence, separations, death in a family. COVID caused a lot of these. So COVID was basically the extrinsic issues which led to academic backwardness. That's what happened. Peer related, again, bullying, or there could be some kind of comparison, competition. So these are the extrinsic factors. In a detailed history, we must have all of this. Again, another way to distinguish between the intrinsic and extrinsic is these are the children who would have long-term problem, the one who are intrinsic causes. Will have a long-term problem, persistent long-time difficulties in studies, while the intrinsic one, they could be more event-related. So they could live for a year or two and the parents will give a history. In that school, the child was doing very well, the child was getting very good marks, but now the child is struggling. So you could give them, you could consider the extrinsic factors in those cases. Another thing what I wanted to say is there's a lot of thing about COVID because there was a lot of disruption in academics. the way the children learned, most of them learned on screen, and that wasn't as effective as a classroom learning. If a parent gives you a history and it's a cause of concern and they give you a history that it happened during COVID, most of the schools, even we requested them because we were getting a lot of referrals. We also requested them that please wait for a year. There's been a disruption for a year, at least wait for a year before referring. But overall, we could say that the children who had a problem pre-COVID are the children who continued to have problem post-COVID. The children who had a problem during the COVID phase were resolved within 1 year of proper effective learning. Epilepsy is very commonly associated with poor academic performance. Now, association is higher with the resistant and syndromic epilepsy. There's higher incidence in the left temporal lobe epilepsy as when related to the language areas, and AAD also causes a problem, and more of the reading and maths difficulty. They don't have much of writing difficulty. Dysmorphism is something, again, when we see, while we are doing the rest of the evaluation, we must take a detailed academic history related to, because most of them will have cognitive impairments, academic difficulties, and sensory impairments. So it could be even attentional problems. So a lot of secondary microcephaly is associated. Fetal alcohol syndrome could have MPS, SOTOS. So, but thankfully we don't see them so common, but Downs, as I showed, would have a problem. Neurofibromatosis will have a lot of learning difficulty. In fact, we had a case of two siblings having neurofibromatosis, and both of them had a problem in academics and diagnosed. One was dyslexia with dyscalculia, the other was only dyslexia. So we had a case there. Tuberous sclerosis again would have the problem. They present more with attentional problems and autistic features. But it will impact learning definitely. Sturge-Weber syndrome. Fragile X is something which we again see commonly, and any child with, they come to us, and quite a few times they get diagnosed as Fragile X later because they come to us for academic problem. And hyperactivity. Turner's, Klinefelter's, a lot of them. So most of the syndromic babies, so the message here is that if you see a child with dysmorphism or a genetic syndrome, please do what you need to do for a child with academic backwardness. Now, how these children present in our clinics? Now, I would say, I should actually put the last one first, parental stress or anxiety. I've had a physician refer a parent mother to me because the mother was suffering from hypertension and the child had a problem with academics. So that was the cause. And then we diagnosed and we worked backwards. While the mother was on antihypertensives, we worked with the child with the specific learning disability, did the entire management part of it. School refusal or phobias is again something which is very common with these children. Inattention, hyperactivity. Hyperactivity is more worrisome than inattention. An inattentive child is okay, easy to manage both at home and at school. But what is more common is the inattention part. So that's something which gets missed out. A lot of aggression and tantrums to study, refusal to write, not wanting to go to school. So those are very important things the way child will present. So reading difficulties, if we become proactive and keep just some 5th grade passage in our clinic. As it has been talked about, you have the growth charts and you have the TDSC under your table. If you could keep this under the glass and just pull it out and give it to the child to read, you would see the struggle the child has to read. They are not able to read simple words, very slow, difficulty in decoding, blending words, very laborious. They may read with finger tracing. So you've seen children. So we just know that there's something not correct and this needs to be looked into. Writing, and make them write on myself, my mother, my school, my doctor. They may write some nice words for you as well. So and just give them a plain paper. If for a smaller child, just draw. I mean, it's nice to just suddenly, de-stress and draw a flower and give it to them and tell them to color for smaller children. So what it requires, it's no rocket science, it's not crores of rupees, but the quality of life. Please understand the child who's now 18, I spoke about. You imagine he's third standard level. You think he's not visited pediatricians till he was 12, 13? You think he's not visited other physicians? But imagine a child who's like 18 years old and doesn't know what to do. And hence on, the child is only expected to read, write, comprehend, listen, present, do something, which is all related to academics. And we've missed so many years out there. So it's extremely important. Then spacing and margins are usually poor. This is how they write, and I'm going to rush through now. Maths, there are basic calculation errors, mental maths issues, reasoning. So basically calculation and reasoning problems. What is the role of a pediatrician? Awareness in the community, screening, diagnosis, right referrals, and certification. Awareness, please display material in your clinic related to dyslexia, school readiness. It just needs nothing, just a colored printout. And let the parents read it. Talk to a professional group. Put reading material in your clinic. This is something which is very simple, looks very colorful. Parents will come and read. You have it available in different languages also. So readiness is something which you need to emphasize. Screening in OPD, ask for red flag signs, talk about grade related academic tasks, ask for notebooks and I need 2 minutes. Ask for notebooks and report cards. You can color code the children whom you think needs to be monitored. This is the very simple way to do it in the clinic. Red flag signs I already spoke about. Evaluation, take a detailed history, and academic history is very, very important here. Vision and audiometry, get it done. Psychological testing, I think they will talk about it. It's the same for all the academic backwardness. Educational testing and psychiatric consultation, OT and speech evaluation. Okay, neuroimaging basically has no role unless you're looking at a comorbidity or you're looking at a high-risk child. Okay. Now, follow-up monitoring is important because what happens is now this child 10 years back went to a therapy center, did some therapy, never went back. They come to us, we send them for referrals, but we never follow up. So if we have the color coding in our clinics, we will ask them, we will write it down. No, the child was sent for therapies, child was sent for special educator, child was sent for an assessment. Next time they come, you ask them again, you reinforce, and then you tell them why you want it to be done. So it's extremely important to do that. Look for regression and new behavioral problems. You need to titrate therapy or add intervention if required. So we need to know a lot about therapy than we know right now. Parental counseling and vocational guidance. They come to you for that also. UDID certification, I won't dwell much, but it's something which is online available. Every child with every disability. Now there are 21 disabilities. All of them need to get this certificate for getting long-term support. Role of teachers and counselors, early detection, ask for academic history, that's fine. I think we need to educate parents because this parent broke my heart because she was such a sincere parent and she did everything what she could, but nobody really told her what she needs to do. And we get and this is a first generation learner in an English medium school, right? So school readiness, periodic monitoring, grade-wise checklist are available and parents should look at that. Does my child at 5th standard know this? If he doesn't, then I need to do something about it. Management, medication, if you have a comorbidity, ADHD and has to be managed. Counseling is important, special education, speech therapy, help at home. Provisions, all these children get help from the educational board, so they get extra time, they get a reader, writer, whatever is required. I'm not saying everybody gets it. And they get calculators, spelling errors are condoned, they can get a subject change. So you can help them mainstream if you do your bit, and then they do learn. Take-home messages, it's a spectrum of presentation with a lot of comorbidities. Possibilities of these conditions will interfere with the favorable outcome. So if the child is a high-risk child is, severe epilepsy, then it will affect. And common associations could help identify the high-risk group, and continued support, and multidisciplinary support is needed. Thank you so much for your patient here.
Thank you, madam, for the excellent overall view. That's bird's eye view of Australia school performance. Any questions she will be able to answer? Next question. Okay. She has told you that grade-wise sheets. We are planning to grade-wise sheets just.
Yeah.
And we have a tool called Tamil Nadu Dyslexia Screening Checklist, which contains 35 questions only, and it is validated and it is used in the Poor Scholastic Performance Program, which is launched in the last year by IAP, Central IAP, and this contains this tool with 35 questions. If anybody wants, I will refer. And we are having this booklet. If anybody has not received this booklet, can receive it from me. It contains immunization and developmental card. In the 4th and 5th year, when we do this, we can identify the early signs of learning disability. We need not wait till 7 years to interfere. We can, at that time, we can stimulate these children, and these children can be prevented from going for SLD. Thank you for this session, and congratulate our madam for the continuous service to the society for nearly 20-25 years. And she is having a free service area in her area, and she is giving free treatment to so many people. Thank you, madam. Thank you for the opportunity for the organization.